distinguished chairpersons and enthusiastic audience. I'll be giving a very short talk on the tips and pearls of PHECO and SICS, that's management of the nucleus. We all know that managing the nucleus is the trickiest part of doing cataract surgery, because on it depends on the success of the surgery, and it draws heavily on surgeon's experience and skill. And in small incision cataract surgery, we don't have a PHECO machine to help us out. Of course, there are many types of nucleus delivery: visco-expulsion, PHECO fracture, PHECO sandwich. The PHECO fracture, the PHECO sandwich, and the PHECO trisection were first popularized in the United States in the 1990s. And of course, you could have a smaller incision in that, but you had to do a lot of manipulation in the anterior chamber. And in Indian eyes, especially where we have a lot of brown and black cataracts, as it is, the cataract occupies the entire anterior chamber, and to put in two instruments more was more troublesome, and of course results were not that good. So it is only when the snare technique was found out in Nandurbar, Maharashtra, but it's only when Dr. Blumenthal came out with his gliding nucleus, or the Arvind Eye Care system came out with the visco-expulsion technique or the irrigating vectis technique, that small incision surgery really became popular. Before we go on to a small video, of course the first step is to get a nucleus into the anterior chamber. The tumbling in which the nucleus is just flipped looks fast, looks easy, is very impressive to look at. But then, as Professor Malik was saying, we need a very good CCC and a good hydrodissection to get the nucleus out first. If our CCC is complete, then more than half the job is done, because then that imparts a lot of stability to the back and our job becomes easy. If we can't do tumbling, then we can rotate it using one or two instruments. Rotation is slightly slower, but it is safer, and especially is to be used in a harder cataract. And I would always say that if you are a beginner, then you dial the nucleus up, you gently rotate it up, and that's even in small pupils, even for very experienced surgeons, that's the best thing to do. And once the nucleus is in the anterior chambers, we have to ensure that the nucleus floats in viscoelastic. And there should always be viscoelastic between the nucleus and the cornea, especially in conditions like ours where we have a lot of hard cataracts and brown and black cataracts, and not the instrumentation, then the nucleus itself may cause endothelial damage. And the side port is an excellent route to ensure this, so please have a side port in all your tests, as Dr. Malik and Dr. Goel were showing us. Okay, here we have a symbol which is actually rotating the nucleus up. Now this takes a slightly more time, but this is very, very safe, and it is a single-handed technique. As Malik sir had shown us, with two-handed techniques it will be easier, but then you have to manage two instruments. The visco is being put on the sides, being put below and up, and if we gently press on the lip, the nucleus slowly glides out. When we are using an irrigating vectis, it's the same as we are putting in the vectis and getting it out. And while getting it out, we gently irrigate. That fluid that goes in ensures that the bag becomes full, and it is pressing the lip which ensures that the mouth opens up and the nucleus quickly glides out. Before delivering the nucleus, and this whether we are doing it with Blumenthal or irrigating vectors or visco-expulsion, we must always ensure that the tunnel is adequate. As Dr. Goel had said, a trapezoid tunnel works best to see that the nucleus is completely bathed in viscoelastic. And for those of us who are beginner surgeons, having a brittle suture, a superior and an inferior rectus suture helps a lot, because when you pull on the sutures, they give pressure on the globe, and when you open the mouth of the incision, automatically the nucleus will glide out. And the gliding of the nucleus is very, very important. If a nucleus suddenly comes out, it will cause decompression, and there could be a posterior capsular rent. So having a very controlled exit of the nucleus is very, very important. And again, as Professor Goel had said, a trapezoid tunnel is ideal for nucleus delivery. When we see a cricketer taking a catch, he holds his hands like this, because then the ball gets in completely. So the inner lip of the incision is much bigger than the outer lip. If we have a rectangular tunnel, then getting the nucleus out is not very easy, and of course it's astigmatically also not neutral. And again, in visco-expulsion or irrigating vectors technique, we ensure that the irrigating vectors does not catch the iris lip or the pupillary sphincter. Because if it does that, and we are now tucking it, pulling it out, we can actually damage the inferior root of the iris. And that, of course, is very, very difficult to suture. And again, irrigate fluid, pull the brittle sutures, and open up the lip of the incision all at the same time. So in some ways, it is like getting a toothpaste out of the tube. We have opened up the nozzle and we are now gently pushing from below. So again, when we try to take the toothpaste out, we are gentle, because if we press too hard, too much of toothpaste will come out, which is what we don't want. And again, when the nucleus is in the anterior chamber, from here there is no cushion of viscoelastic, so there is a chance of iris injury, there is a chance of endothelial cell damage. While this is correct, when you have viscoelastic now bathed all over. And I think these are the two pitfalls that are there if nucleus management is not done properly by any kind of technique. One is, of course, we have tried to maneuver out through too small an incision, and there is too much of fiddling in the anterior chamber, and this is what we get, a persistent corneal edema, which can lead to decompensation. And secondly, when we are trying to get it out from this superior tunnel, if this lip of the pupillary sphincter is caught between the vectors and the nucleus, then we get this inferior iridodialysis, which is a nightmare because it bleeds a lot and it's very difficult to suture, because as cataract surgeons we are all used to suturing superiorly, not inferiorly, unlike corneal surgeons. And finally, of course, when we are doing it initially, whether it's small incision or phaco, please choose the cataract. So you avoid small pupils, avoid hazy corneas, and avoid very hard cataracts, because in all three of them, when doing a nucleus delivery, we can land up with a problem. Thank you.